Go a little bit further up towards the basilar system as we move from the bottom to the top. And okay. And I have some conflicts of interest, so I was fortunate to spend 5 summers of my life in Alex's house with Pierre, writing these books. And these books were really written by ourselves. Most textbooks, you have a whole bunch of co-authors, but we actually wrote these books ourselves over a 5-year period, which was quite an experience, especially since none of us is actually typically born with access to the English language, so we have a lot of editing to do, as you can imagine. And then subsequently Timo came to Toronto, and Timo was fully active in publishing these books where I did very little, but I was very honored to be included by him. The Basilar Artery is formed as the result of a combination of 2 fusion phenomena simultaneously occurring. Upstairs, cranially, the fusion of the 2 posterior divisions of the internal carotid artery in front of the pontomesencephalic sulcus, and caudally, the fusion of the 2 longitudinal neural arteries as the upwards extension of the anti-spinal arterial system. I'm going to show this to you. And this fusion phenomena occur at the same time and in step with the regression of the segmental anastomosis, like the trigeminal artery and so on. So first, the cranial fusion phenomena between the 2 posterior divisions of the internal carotid artery. You and everybody else and ourselves too, we tend to call the carotid termination where it divides into the middle and anterior artery. This is the top of the internal carotid artery. But if you listen to experts in embryology and phylogenetics, actual termination of the internal carotid artery is not at that level, but it's more proximally where it splits off into the posterior division and the anterior division. The anterior division is the anterochoroidal artery, and the anterocerebral artery is a subsequent middle cerebral branch, and the posterior division, which eventually supplies the upper basilar territory towards the posterior fossa. So the posterior division of each internal carotid artery represents the future posterior communicating artery, coming off here, which feeds the future P1 segment down the upper basilar system. So initially the internal carotid artery, ipsilateral, actually and its contralateral internal carotid artery supply together the upper basilar region and territory. Caudally, so further down, there will be fusion of the 2 longitudinal neural arteries that the insect showed you numerous times, which is in fact an upward extension of the anti-spinal arterial system, and this again occurs in step with regression of the segmental anastomosis. And we've seen the hypoglossal, the trigeminal artery, etc. So these longitudinal neural axes, which will fuse in the midline, on both sides, they'll fuse in the midline, and represent the upper extension, basically, of the and the continuation of the anterospinal arterial system, forming the basilar system. And originally, as I said before, the internal carotid artery is supplying all of that, mostly from above, through the posterior fusion between the posterior branches of the internal carotid artery, future posterior cerebral artery. You saw this already from Sarintra, so the whole system is in tandem and in coherence with each other, and the anti-spinal arterial system behaves in the same way, the fusion phenomena behave in the same way, ongoingly all the way from the bottom to the very top of the basilar artery. And you've seen this already from Sarintra, but it's good to refresh again. So at each segmental level, there's segmental arteries that go to the anti-aspect of the spinal cord. The then endosclerotic channels develop between the segmental supply to the spinal cord. Then there will be regression of some of these segmental supply to the anti-aspect and a fusion of the in the midline of these paramedian vessels, and you will see that there is regression of most of the intersegmental supply to the future anti-spinal arterial system. When you have a persistence of supply in the midline, you will often see this fenestration type of appearance resulting from flow coming in from both sides. You can see it on the angiogram. And this goes on all the way to the top, and where we now have the junction of the segmental vessel, transverse vessel, which is the vertebral artery, and the anti-spinal arterial system. You can see it here in the anatomical specimen. This is again a duplication or persistence of the channels in this situation, and then there's a symmetrical configuration eventually resulting in a similar phenomenon at the level of the basilar artery. So again, these paramedian longitudinal neural axis vessels merge and fuse in the midline, as at the same time the basilar artery paramedian vessels merge in the midline to become the anti-spinal arterial system. And at the junction of the upper part of the spinal arterial supply and the bottom of the intracranial circulation, you can see that in this case there can be persistence of unfused spinal arterial systems to the ipsilateral distal vertebral arteries, or you can have that the anti-spinal arterial system has already matured and fused and joined one or two, but in this case one of the vertebral arteries on this side. And notice again, as was mentioned, this is also frequently the site of the nearest closest origin of the pica. So the closest are when you have the configuration when the anti-spinal artery is joining the limb of the vertebral artery, then this will invariably also be the site where the closest pica will be coming from. Now, if you have a persistence or a lack of fusion in certain segments, as in this case, you can see the proximal basilar artery, there is a lack of fusion, so we don't call this fenestration. So the way I remember it, if it's in the midline and there is a hole in the vessel, it is a non-fusion phenomenon. If it's off the midline, and we'll see that later, it's differently called. It's duplication, or it can be called fenestration, but certainly in the midline, lack of fusion are non-fused segments, and the non-fused segments can be large and they can be associated. So as we said, the maturation of the vessel wall, if it's incomplete and resulting in a variation of normal, then this immature vessel wall is prone to develop aneurysms, where there's a high chance of developing an aneurysm. So I showed you a very similar case under these circumstances when you have a lack of full maturation and fusion at the basilar level in this case. At the upper basilar, same phenomenon, you can have a lack of fusion as shown here. And we can, another example, at the very tip of the basilar artery, we see lack of fusion of the two channels. And in this case, that was shown earlier from Chef Lyon, who used to be a faculty member with us, and he showed this very unique case where there's a total lack of fusion of the longitudinal neural axis vessels on both sides, and you have a totally non-fused system. The fusion process of the longitudinal neural axis proceeds from the level of the trigeminal artery upwards and downwards. So this fusion phenomenon at the basilar artery goes two directions. And so it goes and it starts at the level of the trigeminal artery, and it works upstairs towards the carotid posterior communicating and pilon systems. You can see the typical configuration of a posterior view looking from behind the carotid artery. We see nicely the trigeminal artery turning upper basilar artery, which is very big, and a very small size caliper of proximal basilar and vertebral system. So it's imbalanced, the system, and if it's not imbalanced, you can see variations in the size and the flow of these channels. Another example, typical. So the origin of the trigeminal artery is always above the ANCA and below the superior cerebellar artery. And then depending on the caliper size and lack of regression, you will see different flow from the different caliper size basilar arteries, upstairs and downstairs. Now the maturation of the caudal divisions of the internal carotid artery results in the appearance of this area that is also changing in time, and maturation can occur. So originally the blood is flowing from the internal carotid arteries to the pilon segment down, and then later on this process will be reversed, and you will see the flow coming from the basilar artery up. So there is what you call the so-called fetal disposition, where there's a persistence of the prominent supply to the posterior cerebral artery territory from the carotid system, versus the mature situation where the supply to the posterior cerebral arteries is from the basilar artery. So let's look a little bit at the basilar tip configuration. It's further determined by the relationship between the origins of the superior cerebral arteries and the P1 posterior cerebral arteries. And I'll explain that now. So look at this. So we have a spectrum from cranial to caudal fusion appearance, from incomplete to complete maturation. So as I said before, the fusion phenomena starts at the trigeminal level, works its way upwards. It's like a zipper going up. So if the zipper is complete and the whole process is finished, then we have this configuration, the basilar artery with the superior cerebellar arteries and the posterior cerebral arteries coming off at the top separately. But if that fusion, that zipper closure hasn't occurred at the basilar tip level, then we see the actual superior cerebellar arteries arising from what looks to be the posterior cerebral arteries. Yeah, so this has sort of a V-shaped configuration, while this is more the classic shape as we are familiar with. So here we have a classic shape, complete cranial fusion, symmetrical basilar artery, separate superior cerebellar arteries, distinct origin from the upper basilar with its branching pattern of the posterior cerebral arteries. Yeah, this is a complete symmetrical fusion phenomenon. And this is different, right? Here we see this V-shaped phenomenon. We see the superior cerebellar arteries arising almost from at the same point from the basilar artery as the posterior cerebral arteries do, or they can be superior cerebellar arteries can completely arise from the proximal aspect, the pilon sort of segment of the posterior cerebral arteries. So this is an incomplete but symmetrical caudal fusion. Yeah. And another example where this phenomenon is, in this case we have two superior cerebral arteries on both sides arising from the posterior cerebral pilon segments of the posterior cerebral arteries. So this is it's symmetrical on both sides, but the superior cerebrals are not arising from the distal basilar artery, they are actually arising from the posterior cerebral artery pilon segment, creating a symmetrical but caudal fusion, right? You have this V-shaped phenomenon. And here's again, and this V-shaped phenomenon is typical for the arterial configuration in dogs. So in dogs, they always have this same appearance as we see in this case, where you have a caudal fusion, symmetrical. You see the supracerebral arteries coming off the penile segment. Because it's an incomplete maturation, the vessel wall is not perfect yet, it's not mature yet, it's a vulnerability to develop aneurysms in that location. We'll see later on the perforating situation of the perforating vessels, but basically there are three types of perforators at the basilar P1 tip level: the short peduncular, the diencephalic, and the mesencephalic. And in a symmetrical fusion, whether it is cranial or caudal, the perforating arteries normally develop supply on each side. So whether you're dealing with a caudal fusion or a cranial fusion, the tiny perforators come off both sides. So the supply to the adjacent deep substance is from both sides. You can see this in the specimen. Again, the P1 level, symmetrical appearance, left and right. You see perforating vessels coming from both sides. Symmetrical cranial fusion. Right? We see the supracerebrals are coming off independently. There is an exception to this rule, and this is really exceptional in any case. And at the spinal level also, it is invariably that all the vessels on one side supply the ipsilateral side, and we do not see, as Philip mentioned, vessels crossing the midline. That doesn't occur. The exception is this particular configuration, which is called the artery of Percheron, where the deep supply to both sides, basically the thalamic region on both sides, is coming from a single trunk on one side. And so that's an unusual, very unusual situation. Here another example of the artery of Percheron supplying both the left and the right. You can see no or almost no perforators coming out the ipsilateral on the contralateral side. Now, when things are asymmetrical, as in this case, you see in this case on this side we have the superior cerebral arteries coming off the P1 segment, so we're dealing with a caudal fusion. And it's asymmetrical because on the opposite side it's the normal configuration where you have the supracerebral and posterior distinct separate origins. Under these circumstances, the main perforators invariably arise from the high limb, the one that has the high limb, in this case on the right side. So you can see the perforators coming off. In this angiogram, you can see the perforators coming off. That doesn't mean there cannot be anything coming on the left side, but if there are, it's usually very, very, very tiny perforators. So the main supply under this asymmetrical caudal fusion phenomenon is always from the high-limb vessel, and that you can identify. And that will help you to make a choice with respect to putting stents and balloons and sacrifices. So you have to remember that this is obviously the most important vessel to preserve in case you need to treat the region. So the cranial perforators are the most important ones, and they come off the high limb. The caudal ones are tiny and they go to small adjacent vessels. It means no, there is not an absence of perforators, but the perforators are certainly less significant. So in summary, the three types of basilar anatomical dispositions all correspond to variations of fusion of the caudal intercarotid artery division. On the midline, you can have a symmetrical cranial fusion, the fully mature separation of origins of posterior cerebral and superior cerebral. You can have symmetrical caudal fusion, where the superior cerebral arteries appear to be coming off the origin or the proximal P1 segment. And you can have asymmetry, where on one side it's cranial, on the other side it's more caudal type of fusion appearance. Angiographic landmarks that determine the basal tip disposition is the site of the origin of the superior cerebellar artery. That tells you whether you're dealing with a caudal or a cranial fusion. Thank you. Questions on this fusion phenomenon?